The broadcast is now starting. All attendees are in listen-only mode.
Good morning and good evening to some of you. Welcome to the webinar on the management of patients with fragility fractures. My name is Masaki Fujita and I'm the Science Project Coordinator at the IOF in Switzerland. I'm also the Global Program Coordinator for the Capture the Fracture program. Now, it is my pleasure to run this webinar today with our speaker, Professor Serge Ferrari. Professor Ferrari is Professor of Medicine at the Geneva Faculty of Medicine, Head of the Clinical Service and Research Laboratory of Bone Diseases at the Geneva University Hospital, and he is also the Chair of the International Osteoporosis Foundation Committee of Scientific Advisors. Now, before we begin this webinar, I'd like to inform you that all attendees are muted automatically. If you have any questions, please feel free to type your questions into the question box of the panel. Questions are being collected throughout the webinar, and I will voice them towards the end of the webinar. Now, Professor Ferrari, on to you. Please begin when you're ready.
Okay, good morning or good evening, everyone. Welcome to this IOF webinar on the pharmacological management of patients with fragility fractures. This is the goal of our discussion today. I'd like to discuss with you in particular what is the goal of osteoporosis therapy. And by discussing so, I think there are two stages in the way we should think about therapy. The first one being a rapid reduction of fracture risk, particularly in patients at imminent risk, which I will define in a minute. And then once this treatment has been initiated and the first goal reached, which is the disappearance, if possible, of fractures, it's to think how long should we treat in order to restore bone mass and strength to a level where the patient will eventually sustain another fall without a further break. So we're all aware that the fracture risk is very different depending on whether or not we've had a previous fracture. These two ladies here on the left and on the right, supposedly 25 years apart, have very different risk of fractures. The one on the left never had a fracture before, so her risk will be mainly defined by bone density and age, and by fracts. Whereas the one on the right, who has already had vertebral fractures and hip fractures, will have a much higher risk than the previous one. As you know, after a vertebral fracture, the risk of refracturing is about 25% within 1 year. And after a hip fracture, there is a tremendous increase in the relative risk of another fracture, particularly within the first year or two, and then eventually this risk levels off. So this leads to define what we mean by imminent risk, which is really a high risk of refracturing within the first couple of years after an incidental fracture. This is one of those studies showing again what is the actual risk of a vertebral fracture after hospitalization for vertebral fractures in men or women age 60 years or age 80 years. And as we can appreciate, the risk of a second vertebral fracture can be as high as 20 or even actually 25% in older women within just the first year after the initial vertebral fracture, leveling off at about twofold the initial risk when time goes on. The same is true for fractures after peripheral fracture. This is a recent survey from Medicare, women, men above 65, in whom overall, after an index fracture, the rate of a second fracture was 4.3% within just 1 year. This risk increased with age, increased with comorbidities, and was worse after a hip fracture, reaching as much as 7.5% of second fractures within a year after the initial one. Then what the bars show you is that there is no fracture that doesn't carry a high risk. So whether the index fracture was at the wrist, at the humerus, or at the hip, the percentage of second fractures that actually occurred at the hip was between 40 and 60%. So even in women with an apparently mild wrist fracture, there is actually an overall 4 to 5% risk of a second fracture within a year, and of those, about half will be hip fractures. This is another study, also from Johansson, looking at women after a first major osteoporotic fracture, who again shows that the risk of a second fracture peaks within the first couple of years, in this case up to 8% initially, and then going back to about the twofold risk of a population without such a fracture within a couple of years. Indeed, they found that 60% of all secondary fractures in women with a previous fracture occur within 1 year of the index fracture, and another 25% occurs in the second year. So the imminent risk of a secondary fracture after initial fracture really concentrates within the first couple of years, as about 85% of all secondary fractures will occur in that early time point. Now, this imminent risk, which means more fractures occur early on after a fracture, is even more prominent in elderly subjects. So you see here again from that same study, the hazard ratio for a second fracture within 6, 24, or 60 months after the index fracture. And it is particularly after age 70 and then 80 and 90 that you see that the hazard ratio is higher early on and declines with age. Why is that so? Probably because having a fracture in an older age means more frailty and more recurrence of falls, particularly right after a fracture. And also means, of course, that as time goes by, there will be mortality from other causes that may explain partly the time-dependent decline in the risk of a second fracture. So a fracture carries a fracture. They carry most of the second fractures early on, and even more so when we're facing elderly patients. So for all these good reasons, as you know, interventions, and particularly pharmacological interventions, have aimed to focus primarily on patients with hip and then with other types of fragility fractures, and focus on those patients early on with as a goal to prevent the second fracture, at least in this first stage of therapy. Now, we all know that we have notably failed in identifying patients at imminent risk, which means patients with recent fractures, to introduce secondary prevention. That's why fracture liaison services have been advocated and largely developed, because such services provide a link between the trauma service where the fracture has been first seen, or the operating room where it's been operated, and then some specialists in the disease will be able to do the proper diagnostic workup and eventually prescribe or introduce the osteoporosis therapy. You certainly have known that the introduction of such fracture liaison services programs, like here in the UK, has led to a clear change in the rate of fractures prescribed within a year. That is shown here on the left, whereby the uptake of medication within a year after a fracture has clearly been shifted up thanks to the implementation of fracture liaison services. And this has actually led to a decreased incidence of the yearly rate of hip fractures in the UK since those FLS systems have been introduced. Now, it is very important to the IOF to help set up such fracture liaison services, as you know, and then capture them, capture the fracture campaign. As you see currently, there is almost 300 fracture liaison services registered across all continents. And the process is very well known to all of you, sufficient to go online and get support on how to implement a fracture liaison service. Very well aware I am, of course, that there are caveats because it depends on the available resources, but at least the way to develop those systems is now clearly described, and you can submit applications all the time to the IOF, who will evaluate the opportunity to enter your FLS in the fracture system. So let's admit that all this has been put in place, and that we're now able in our hospitals and trauma centers to identify those patients with a fracture at imminent risk of refracturing. What are the drugs available? Well, you all know that we have a bunch of drugs, and here I first emphasize the anti-fracture efficacy of antiresorptives, from the weakest ones on the top to the most powerful ones at the bottom. So on the left is the relative risk of vertebral fractures in those trials with the drugs compared to placebo, average reductions ranging from 30 to 70%. And on the right, the reduction in non-vertebral fractures with those drugs, not all reaching that endpoint, but certainly some treatments, including some bisphosphonates and denosumab, reducing non-vertebral fractures by 20 to 25%. Hip fractures is a great concern, of course, because of morbidity, mortality associated with it. And we see here the evidence that we have of therapies reducing hip fractures. For those who have reached that evidence, it's usually a 40% reduction in the risk of hip fractures. So we have those drugs, we know they reduce fractures, but of course the more precise question today is in the context of a fracture that is on service, having identified a patient with a recent fracture, what is the evidence that those drugs actually reduce the imminent risk of refracturing? And that evidence is partial. Certainly, we have one study with zoledronic acid once yearly that has been specifically designed to treat patients with a recent hip fracture and therefore at imminent risk of another one. And as you certainly know, this study showed a reduction of clinical fractures by about 35% following a hip fracture. These results are over 24 to 36 months, and also of other specific types of second fractures as shown on this graph. Most importantly, also, certainly as you know, zoledronic acid in that trial not only reduced the rate of second fractures in elderly patients with hip fractures, but it also reduced mortality by an impressive 20+% by mechanisms that we are not going to discuss here. Now, to extend this discussion about what is the evidence that our drugs reduce risk in the highest risk patients, we can look at other studies, and particularly you may have seen the recent study that is a first head-to-head comparison study between teriparatide and an anti-resorptive risedronate in high-risk women. High-risk women defined by the presence of moderate or severe vertebral fractures who are then randomized to this treatment for 2 years. To note that among these high-risk women, 36% actually had a recent clinical vertebral fracture, which puts them, of course, in the highest category of refracture risk. And 72% had previously been on anti-resorptive for some time, as is often the case when we decide to switch to teriparatide. And 10% was also on glucocorticoids. So in this heterogeneous, but I think very representative population of high-risk patients for fractures, results published in the Lancet demonstrated a further reduction of vertebral fractures by about 50% with teriparatide versus risedronate, and also important trends to reduce other types of fractures with the anabolic agent versus an anti-resorptive. Then from that study, subgroup analyses have been published, and I would just like you to focus on this subgroup down there, indicating that the relative benefit of teriparatide versus risedronate was similar whether or not the vertebral fracture was recent. So that adds to the evidence that in patients with recent vertebral fractures and at imminent risk of refracturing, in this case, introducing a bone-forming agent was even more effective than the regular anti-resorptive therapy. Further extending this discussion, going, for example, to denosumab, as you also know, following the evidence that denosumab reduces all types of fractures in patients at risk, there have been subgroup analyses, as shown here, either pre-planned or post-hoc, focusing on particularly high-risk subset of this freedom population. On the left, for example, women at higher risk were defined by older age, low BMDT scores below -3 at spinal hip, and or prevalent vertebral fractures. And in this super high-risk population, again, the drug was shown to reduce non-vertebral fractures by 48%. So by and large, we have several drugs, including zoledronic acid, teriparatide, and denosumab, that have shown not only an overall reduction of fractures, but even in very high risk or even risk population have shown such efficacy. In contrast, you should remember that there is observational evidence, as shown here from a survey in a large database from Spain, that when you look at women who are receiving oral bisphosphonates and who are actually compliant with therapy, the risk of recurrent fractures, despite this well-conducted therapy, has a certain number of risk factors. And among the risk factors identified for an apparent failure of oral bisphosphonates to prevent second fractures is the presence of a fracture. And particularly, as you see here in the red box, patients with a recent fractures and put on oral bisphosphonate and compliant with it kept a more than twofold increased risk of recurring fractures despite the therapy. So I present this data to say that there could be some evidence that in patients with a recent fracture and at imminent risk, the introduction of a parenteral drug might potentially be even more efficacious than the standard therapy with an oral bisphosphonate. Finally, I'd like to stay in this real world by presenting you recently published data from a very large analysis in Medicare again, in which women above 65 years of age who got a prescription for any osteoporosis drugs were followed up in the database for 15 months. And the analysis was done in order to compare their initial rate of fractures in the first 3 months, considered to represent their baseline risk, and the subsequent rate of fractures over 12 months thought to represent the eventual benefits of therapy. And so the effects of therapy are then calculated as the rate ratio of fractures between the 12 months of continuous therapy compared to the first 3 months. And what that study showed was very good news, actually. All the drugs were associated with this reduction in the rate of fractures in 12 months in red compared to the first 3 months in blue. Besides raloxifene, which, as we know, mostly reduces vertebral fractures, but is not so efficient on non-vertebral ones. Now, there are some differences in the relative risk reduction over time, and in particular, women at the highest risk, those who, as we see on the graph in the blue column, would be preferentially prescribed denosumab or teriparatide. Those women had a relative risk reduction in just 15 months, which was actually even greater than women at slightly lower risk and prescribed bisphosphonates. So again, emphasizing that targeting the highest risk women and then giving them parenteral drugs, here in this case, particularly denosumab and teriparatide, would be extremely beneficial in terms of reducing non-vertebral fractures, including in women 65 years of age and older, even in real life conditions. Now, the last step of this presentation would like to focus on now the longer term effects and needs in osteoporosis management. We have come to the point so far in my presentation to acknowledge that women with recent fractures are at imminent risk, and we have drugs that are effective and when prescribed in this high-risk population have early effects in reducing the risk of second fractures. Now this therapy has been initiated, and admittedly, if the compliance is there after 2 or 3 years, the question becomes, for how long should we treat, and what is the long-term goal of therapy? Not the short-term goal anymore, which we have defined as a reduction of second fractures, but the long-term goal. Now, thinking of the long-term goal, one should just keep in mind this relationship between bone mass, bone strength, and fracture rates. So this is now an untreated population. It comes from Eastern, the Reykjavik cohort, followed 5 years, with measurements of hip bone density shown as the x-axis and measurements of the strength of the hip evaluated by CAT scans and FEA, that's in Y. Well, first of all, we see there is a very good correlation, of course, between bone mineral density at the hip and bone strength at the hip because bone mineral density is and remains the main determinant of bone strength. But what's really interesting here is to look now at those women, the circles, who had a hip fracture, because we'll then observe that the vast majority of women with a hip fracture actually had a hip strength less than 4,000 Newton. 4,000 Newton is about the strength you need in your hip to resist most of the falls without breaking your hip. And that corresponds more or less to a bone density that approaches normality, -1, perhaps around -1.5. So intuitively, one would think that the long-term goal of therapy is to treat for as long as it takes to bring women from the left lower corner of the graph with the lowest bone density and the lowest strength, somewhere to the right, to this crossing of the lines where then their hip would be strong enough to eventually resist a break even if they fall. Which in other terms means that monitoring BMD and looking at BMD increases and then the absolute BMD T-score over time would be an indicator of when and at which point we have reached proper strength of the skeleton. There is accumulating evidence for that. This is the famous meta-regression from the FNIH initiative, putting all our clinical trials in osteoporosis therapy in one graph. So each color is a different drug, each circle represents the size of the trial. And what they have shown here is this inverse relationship between the hip BMD gain in treated versus placebo and the actual relative risk of a fracture, in this case of a hip fracture in the trial. And what this represents is that the greater the hip BMD gain, the lower the fracture risk of the hip in the trial, irrespective, in a sense, of the therapy that was used. And they calculated that 60% reduction of hip fracture risk was actually explained by this gain in hip BMD. More evidence from the FREEDOM trial showing the relationship between the T-score at the hip in the course of therapy, 3 to 10 years, and the risk or the prevalence of a non-vertebral fracture in the year that follows. And we see again a very nice inverse relationship by which the higher the hip BMD reached at the hip, the lower the rate of fractures in the year that follows. So that when the hip BMD reaches again T-scores close to normal, around -1.5, we seem to have reached the maximal reduction in hip fracture risk, and then things level off, indicating that going above that level of hip BMD will not have a large effect on risk reductions anymore. Now, in contrast, when patients who have been treated stop therapy, they will remain at high risk of fractures if they have not reached a proper bone density. This is from the FLEX study, those famous women on alendronate for 3 to 5 years, who were then re-randomized to continue therapy 10 years or stop. And we're looking here at the group that stopped alendronate after 5 years and went to placebo. And what is clear on this graph again is that women who kept bone densities at the hip below -2.5 after 5 years had a 30% recurrence of fractures in the 5 years that followed. Whereas when their bone density had been brought to higher level, particularly again around -1.5 and above, the risk of having another fracture in the next 5 years was extremely low. So you've seen here a convergence of data and evidence indicating that beyond the initial fracture risk reduction, treating to bone mass, to T-scores that are good enough, certainly above -2, is accompanied by a progressive reduction in fracture risk, to the point that when we have reached that therapeutic goal of no fractures for a few years and an appropriate BMD, one could think of either some therapeutic window, if it's on bisphosphonates for some time, or if it's with a reversible drug like teriparatide, denosumab, or other reversible drugs, maybe just a consolidation therapy for a year with a bisphosphonate and then again a therapeutic window, but again only when that treatment target has been reached. So before we engage in discussion, please allow me to conclude as follows. Patients with recent fractures are at imminent risk of refracturing, with rates that range from 5 to 20% refracture in 1 year. The highest refracture rate is after vertebral fracture, and also followed by women who are older, have more comorbidities, and who have had a hip fracture. So identification and immediate treatment of these very high-risk patients, I think, is really mandatory. And for that purpose, the development of fracture response services is a very good tool to do the job. There is good evidence, of course, that osteoporosis drugs reduce fracture risk. And I've shown to you that this evidence extends to patients at high risk, such as patients with recent hip fractures or recent vertebral fractures. And this is particularly true, I think, with parenteral drugs such as hyaluronic acid, denosumab, and teriparatide. And once we have installed this therapy, treatment should be pursued not for a fixed duration of time, but in an individualized way until bone mass, which I mean BMD scores, are restored to near optimal bone strength levels that correspond certainly to T-scores on average above -2 at the hip. With that, I'd like to thank you for your attention, and I'll be very glad to answer your questions.
Thank you very much, Professor Ferrari, for your presentation, highlighting the importance of managing patients who are at risk of imminent fracture and covering the various pharmacological interventions. Now, you've also underlined the treatment gap and that there are a wide range of treatments available for patients. And it's important to state that patients should be given the most appropriate therapy. Now, you also mentioned about FLS focusing on high fracture patients, improving identification and treatment initiation. Now, we have a few questions, and we would like to move on to the questions and answer session. Now, question 1. Why are patients at imminent risk of refracturing, especially in the first year after the first fracture?
So that, of course, is an important question, and probably that what determines the risk of refracturing depends on the type of the initial fracture and also on individual determinants. So the very high risk, 20-25%, of having a second vertebral fracture after the first is probably largely determined by the changes in the spine geometry that have been caused by the first fracture. Particularly grade 3, a wedge fracture, will clearly create a deformity in the spine that will impact by increasing the loads and the stress on nearby vertebrae, initiating this domino cascade of vertebral fractures. More generally, though, patients with a recent fracture have an increased risk of falling early on after initial fracture. It's obvious that a patient with a hip fracture recently operated is less stable walking, but it's also true for other fractures. I've shown you data from Medicare showing that after a humerus or even a wrist fracture, there is a 5% increased risk of second fractures in the first year, and that half of them would be at the hip. Well, I work in a geriatric hospital, and I see patients with humerus and wrist fractures treated conservatively with a cast. If you put a patient with a cast on her arm on a carpet to measure the way they walk, you will see that this simple cast has altered their walking speed, their balance, and their gait. So there is clearly, after a fracture, a further destabilization of the patient that would increase even further the risk of falling and breaking. And then, if the third reason is that if the patient has been immobilized, there could be further accelerated bone loss that will further fragilize the skeleton. So it's a mixture of factors, both linked to the biomechanics of bone, particularly for the vertebrae, to the general status of the patient, the risk of falling, and the risk of further losing bone that could explain why there is such a high risk early on.
Thank you, Professor Ferrari, for the detailed answer to this question. Now, next question. I believe this was slide 5. Now, you said that refracture rates increase with aging comorbidities. Would you
Yeah.
be able to specify which comorbidities in particular and why this may be so?
Oh, there is a bunch of them, but I think what this says is that patients who have multiple comorbidities, cardiovascular, respiratory problems, dementia, etc., those patients are the frailest ones. And therefore, the presence of one or multiple comorbidities will further increase your risk of fracturing, probably again because it will further increase your risk of falling early on once you've had the first fracture.
Thank you for your answer. Now, moving on to question 3. So, do you recommend anabolic agents such as teriparatide as first-line therapy in combo with BPP or without? And for TPTD, teriparatide, does this only apply for postmenopausal women with severe osteoporosis?
Okay, so do I recommend a bone forming agent in the first place? Well, as we all know, I mean, teriparatide is the only one we have, and in the US, abaloparatide have been positioned as second or third line therapy, particularly after anti-resorptives when there is evidence of treatment failure. Now, we're all aware that this is not the way the studies have been designed, and that those drugs, they work even in naive patients in terms of fracture risk reduction. I think what the recent study, and particularly the Vero study, has shown is indeed that as compared to an oral bisphosphonate, it's more efficient to reduce fractures in high-risk patients. So if I have to choose, I would rather start with teriparatide, but we need to be aware that the study compared to bisedronate maybe would not be such a marked difference against denosumab or zoledronic acid. We don't have that study. I cannot say so. I think generally speaking, it's obvious that patients with prominent vertebral fragility, so vertebral fractures, low BMD at the spine, and or particularly recent vertebral fractures, they are the most likely to benefit from teriparatide compared to an anti-resorptive. In patients with peripheral fractures, wrist humerus, or hip, I don't think we have real evidence that teriparatide would be better than a potent anti-resorptive such as zoledronate or denosumab.
Interesting insight, answer. If we can move on to the next question, which just came in fact, when we change denosumab to BPP, for how long should bisphosphonate should be continued?
When we give bisphosphonate before or after denosumab?
Well, I believe after denosumab is the question.
Okay, well, it's a good question. And the short answer is we don't know, because there is so little evidence for the benefits of bisphosphonates after denosumab. The little evidence we have goes for 1 year. Do we need 1 year? We don't really have the studies to say we need 1 year versus 6 months or 2 years. So currently, I strongly advocate that any patients who has reached his therapeutic goal with denosumab and who needs a consolidation therapy with a bisphosphonate, either an infusion IV Zol or an oral prescription, should be treated for at least 1 year. But I strongly advocate monitoring bone turnover markers, particularly CTX, to make decisions about whether the treatment is sufficient and needs to be renewed or not.
Thank you for your answer. Going back to anabolic drug, there's a question on this. How do you see the therapeutic strategy using AR and anabolic drugs for the long-term resaturation of bone strength?
Well, again, it very much depends where we start. Okay, so if we start with an anti-resorptive agent, and then there is sort of failure of therapy, particularly if there is a recurrent vertebral fracture, it's a very good case to introduce teriparatide. And then we all know we can prescribe for 12, 24 months, depending on the outcome, after which it's possible that an anti-resorptive is needed again. If we go for high-risk patients and want to introduce teriparatide first, we're going to treat a year or two, and then we'll certainly need the relay by anti-resorptive for probably several years, whether or not it's denosumab or bisphosphonate. The other question is, should we combine those therapies? In my view, the evidence for combining bisphosphonates and teriparatide is not very good. I mean, there is no real evidence that there is an additional benefit at 1 year. There is some evidence that denosumab plus teriparatide further increase BMD at 1 and 2 years, particularly at the hip. And this could be a combination therapy that would be beneficial to high-risk patients with very low bone densities, at least for a year or even two, notwithstanding all the questions about reimbursement indications that can be really a barrier in many countries to do this combination therapy. And again, we have no data on fractures there, so we're really treating the bone density.
Indeed, I think that's an important point that you touched on. Reimbursement could be a factor that could influence this. Now, next question, and a relevant question, what is your take on drug holidays?
Like many of my colleagues, I don't like the word. That's why I use the word therapeutic window. I think a therapeutic window is appropriate when the patient has been treated many years with bisphosphonate and has reached the goal of therapy, at least 5 years of fractures and the bone density at the hip that is above -2. Then, because of the slow reversibility of bisphosphonates effects, a therapeutic window with good monitoring, perhaps of bone tumor markers, but particularly repeating DEXA 2 years, could be advocated. With the reversible drugs, of course, it's not possible. Again, after teriparatide or denosumab or even SERMs, there will be accelerated bone loss. So we don't speak about the therapeutic window, even less about drug holiday. We speak about the consolidation therapy with the bisphosphonate, after which, again, if the goals have been reached, some therapeutic window could be taken again with close monitoring before eventually reintroducing the drug if bone density goes down again.
Thank you, Professor. I believe we have time for one more question. Now, and I think this question will be a good question to end this webinar, as it's on FLS. Now, you mentioned that FLS is a clinically effective solution for identifying patients who are at imminent risk of fracturing. And also, it could lead to improvement in treatment initiation. So how exactly does an FLS improve identification, evaluation of patients for secondary prevention, and improve treatment?
Well, there is two parts to this answer. It helps, first of all, making a correct diagnosis of the underlying disease that has led to the fracture. So recognizing that it is bone fragility, osteoporosis, and having a diagnostic code at the patient when the patient gets out of the hospital that not just said humerus fracture, but that identifies that osteoporosis as the underlying cause is important. So again, it may need DEXA scan, but even without a DEXA scan, I think that the liaison with a specialist in bone who would identify the vertebral fracture or the hip fracture or another fracture as being fragility, therefore osteoporotic in nature, is very important from that point of view, because as we certainly know, the link between traumatic or non-traumatic fractures and osteoporosis is seldom, if ever, made in the patient's mind. And without a diagnosis of osteoporosis, treatment will not be initiated. So that's the first step. Then the second one is the prescription. And there are, of course, different ways that an FLS can initiate prescription. It can give advice to the managing physician in the hospital or to the patient's doctor out there, or it can actually prescribe the drug. So we've done a study recently in patients with vertebral fractures in our hospital that are captured in a vertebral fracture liaison service here in Geneva. And we have clearly shown that the rate of prescription at 6 months after the vertebral fracture is detected is much better if the treatment has been initiated in the hospital rather than just advised to the general physician of the doctor. So I think fracture liaison services are crucial first to put a diagnosis on the fragility fracture, to identify patients, therefore, with osteoporosis at high risk, and to initiate therapy by an active prescription at the patient discharge.
Thank you for your answer. I think it's great to emphasize that FLS leads to better diagnosis, as you elegantly explained, improving treatment initiation rate, but finally also in the long term, medication compliance, which is a big issue. Now we are coming to the end of this webinar. So I would like to thank each and every one of the participants for joining us today. We really do hope that you enjoy this session. We, as usual, will post recordings of this webinar on the CTF website. If you go to the webinar tab, if you click on it, you'll be able to see all the past webinar recordings, including this one. Now, after this webinar is closed, you'll be asked to fill in a survey. We appreciate always your input and comments as we like to deliver the webinars that you want and need. Now, last but not least, if you have any questions, please don't hesitate to send them over to capturethefracture@iofbonehealth.org. Now, on that note, Professor Ferrari, thank you very much again for making the time to
welcome. Thank you for attending.
And we wish you all a good afternoon and good evening. Thank you very much.
Goodbye, everyone. Thank you very much for attending. Bye-bye.
Goodbye. Thank you now.